Welcome everybody, Lehigh Valley Health Network Carbon Hospital. Is it great or what? How many people have been here as a patient or visitor? Raise your hand. Is this unbelievable in Lehighton? It's awesome. Thanks for coming. So I was asked to talk today about same-day knee replacement surgery, but that's not what I do. I do rapid recovery outpatient total knee resurfacing. And so I'm going to explain the difference to you. Okay, so that's what we're here for. Today I actually did 5 of these this morning, ages 55 to 83. They're all home already. They were home by 1 o'clock. Amazing. I've been doing this 30 some years and the evolution has been unbelievable. So a lot of these questions, you know, I answer every day in the office. So before I get started, Lehigh Valley makes me say that this is only for education. This is not medical advice. If you have your own doctors, that's where you get medical advice. This is just for education. And plus it covers them because they never know what I'm going to say. So they don't take any responsibility for anything I'm going to say today. So this is a disclaimer that sort of disavows them, if you were. Prescription drugs, you know, rank 4th with stroke as a leading cause of death. So I look at the people that are on 10 or 12 polypharmacy when, you know, our medical system, and I have a whole nother talk that goes back to the early 1900s. We are a pharmaceutical-based medical system. It goes back to the early 1900s, and it was really Rockefeller, who you think was a business magnate. But he ruled the pharmaceutical world in the early 1900s. Nobody sort of knew that. And so he took over all the medical schools in the country, the early 1900s, and he closed half of them. And then the half that stayed open, he said would be pharmaceutical based. I'll give a lot of money to these schools, but we're taking everything out of the curriculum that has to do with vitamins, foods, natural products as health related. So all of the allopathic schools from the early 1900s eliminated everything about nutraceuticals, vitamins, foods as healthy, and it's pharmaceutical based. So when you look at some things and you drill down, that's where it all comes from. That's why docs know very little about nutraceuticals. I had a year of pharmacology. I had a 1-hour lecture on nutraceuticals. I asked Mike to come, Mike Kuzo. He was like our food taster, I think. I forget when we started here, Chris. When did we do our first?
Here? I think September.
Yeah, September. So Mike was our food taster.
That was the first one.
I think Mike was. So we give him credit. So Mike had both knees done, but I think we did the other one at Lehigh Valley down in Allentown, and he's from up in this area. But what a wonderful ability to make this an outpatient center of excellence and bring our team here. Wonderful facility. And Mike, just stand up for a second, just for a couple questions. So just, you know, give me your experience of the Carbon Hospital, how you did that day. What time did you get here? When did you go home? That sort of thing.
I got here at 7 o'clock. I was home at 11.
Home at 11. It's a little.
And I was walking the same day.
That's a little long. Something must have happened.
You know what I mean? But no, I suffered for years. Oh my God. And I seen him. I had that Instaflex I took. I had all the shots. None of that stuff works. And finally I went to see him because I was getting bull-legged. It was that bad. And he says, when the cartilage is gone, it's gone. There's not a drug out there that's going to replace the cartilage. So I went to see him. I had the first one done, and that was easy. The second one I had done here was even easier. I didn't take any of the narcotics at all. And it's not quite 6 months, and I walked a mile yesterday. Every other day I walk about a mile. And I get a little bit of swelling yet. I come home, put ice on it, next day I'm fine. So, I mean, he's the man.
So, well,
he didn't pay me to be here.
Wait, so, and again, it's still a real operation. You don't want to underestimate it. So you go home, you feel great, you know, feel great the next day, I'm over the hump. And then third and fourth day, reality hits because the block wears off. But it's not terrible. It's all about patient engagement and understanding, I didn't do anything wrong. It's going to hurt the third and fourth day. So we just back off. So, you know, first day we do nothing. Second day we give you exercises to do 5 minutes a day, the whole day. Third day we back off. Fourth day we back off. Fifth and sixth day is common sense and we go back up. So if you went to therapy, they schedule patients 3 times a week for an hour. And, you know, they don't always understand our procedures. So that's why we found the first week we educate the patients and then we see them back somewhere between 7 and 14 days and we make an individual decision. If the patient's motivated, some people are motivated, they don't need a coach, they're, you know, busy, they've done the exercises, they show up with 120 degrees of motion, they're doing great. It's hard to improve on that. You know, if he said, I went to therapy, we'd say you have a great therapist. But he's doing great on his own. Nope, you're not sitting down, stand. So, you know, that's what we do. But there's other people. Genetically, there's some people form more scar tissue. They get lymphedema, like we stole from the breast cancer world. I stole the best lymphedema therapist 25 years ago down from Good Shepherd, and she works full-time in orthopedics. We were the first ones in orthopedics to hire a lymphedema therapist because we did trauma. You break your leg, it swells up. There's a lot of people, 60, 70, 80, 90. They have swollen legs when they come in. They have venous stasis. They have some cardiac disease. So you'll get swelling. And after we operate on the leg, it's going to swell more. So we identify that early. We do lymphedema therapy on the lower extremity. And so we figured all of these things out that we didn't know years ago. So Mike had, again, before surgery, we start a couple nutraceuticals called fish oil and L-arginine. It's in the medical literature for years. If you're in the ICU and you can't eat because you've had a stomach operation and they have a tube down your nose or they have some parental nutrition, you have to get nutrition. The 2 products that are in every ICU feeding tube are omega-3 and L-arginine because they lower your risk of infection and wound healing. And so why don't we do this in orthopedics? So we do. Even if you look at, you know, Nestle and Abbott, they're out there with these immunonutritional drinks that are mostly for general surgery malnourished patients, and they have them take them 5 days ahead of time. The main ingredients are protein, L-arginine, and fish oil. Most orthopedics, because we didn't learn it in medical school because of Rockefeller, because he wants us to prescribe drugs. So you do this. These are natural things that you can take that enhance wound healing. But you know what they also do? They decrease inflammation. The basis of all pain is inflammatory mediators. The less inflammation you have pre-op, the less pain you're going to have. So Mike was on that the day before. If they're on, you know, misnomers all over the place. People are on baby aspirin. They're told to stop it beforehand, stop the fish oil. None of this is based in facts. None of this is based in facts. If you look at omega-3 as a bleeding issue, and I have all the literature, you don't have to stop it before surgery. And they say, oh, my doctor said I have to stop fish oil, I'm going to bleed. I said, did he tell you to stop eating fish? No. So there's a lot of misinformation out there. Baby aspirin, if you're going to bleed, they can't do a spinal. There's no contraindication to do a spinal with baby aspirin, so we don't stop it. And what do baby aspirins, you know, stop? They keep your platelets thin. They stop excess of clotting. What's a clot in the heart? It's called a heart attack. What's a clot in the brain? It's called a stroke. And so we're very good with bleeding control in the operating room. We have electrocauteries, we stop bleeding. So we don't worry about actually, even if you had a little bit of bleeding, we stop that. We have new medications called TXA, tranexamic acid, a wonderful addition. We put it in the IV, we inject it into the knee, and it stops excessive bleeding. They didn't have this years ago. I mean, if anybody had a hip operation or a knee operation, you used to have to type and cross blood. You used to have to give blood This is crazy. It was like a bloodletting operation. Now, you know, you don't see that. And before surgery, you know what Mike got the morning of surgery? He got Celebrex, he got Tylenol, he got steroids, he got a neuroleptic, either a little gabapentin or Lyrica, all these things before the operation even started. So these all attack the pain synapses and the inflammation. And then we have, you know, minimally invasive surgery. It's not the size of the incision, it's how we treat the tissues. It doesn't bleed like it used to. We have ice immediately in the recovery room, they're elevated. So all of these things happen in the background, unlike the old days where you woke up and there was nothing and then they gave you the narcotic. So Mike had all of that. And then we have a new long-acting Novocaine that we inject around the knee. 120 cc's, that's a big volume if you think of it. You know, if you think of it, 120 cc's, I think 240 cc's is a 12-ounce can of Coke or something. So we take half of that volume and we inject it. It takes us about 3 minutes because we time it. And it's analogous to a dentist taking a needle and injecting every bit of your gums all the way around. Your whole face would be numb and it would last 2 hours. But this lasts 2 days, but your leg doesn't really feel numb, but that's why you don't feel a lot of the pain. So all this is done before Mike even wakes up in a recliner chair in the recovery room. And he goes, this is great. Where's my coffee, juice? The spinal wears off, he pees, and he goes home. So that's sort of how we get away from that. And then we put him on 2 weeks of an anti-inflammatory, Tylenol, Celebrex, baby aspirin for, you know, stop blood clots at home twice a day, and Tylenol's 3 times a day. And then we get, you know, but we're not mean. We say, here's a week's worth of oxycodone for breakthrough pain only. And most of them bring it back, or they, you know, the 3rd or 4th day they may need it. So everything is covered because everybody has different pain thresholds. How did you do with narcotics at home, Mike?
I didn't take any of it. I still have it in the medicine cabinet. I didn't need it.
Yeah, so everybody's different. But we hear that in half of the people. Like, how can, this is crazy. 30 years ago, this is, you know, that's all, oh, here's our whole pain things. That's sort of all that stuff that we do. And then again, therapy is wonderful. Not going to physical therapy doesn't mean you don't do physical therapy. We're very good at explaining what to do at home. We've picked out those exercises. And again, half of the people when they come back, if I'm not happy, they will go to therapy. But a lot of it isn't as intense as it used to be, 3 times a week, you know, for 3 months. And we never do therapy 2 days in a row. I'm going 3 days a week, Monday, Tuesday, Friday. I go, no, you're not. You don't go 2 days in a row. You don't go to the gym as a weightlifter and lift the same body part 2 days in a row. So anyway, so let's open it up for questions that I said we would do, but all I did was talk nonstop. Go ahead.
I got a good question.
Yeah.
I did my right knee 6 years ago.
Uh-oh. This
It's good.
could be dangerous.
It's great, but on the opioids, my wife refused to have it filled, and I lived on extra strength Tylenol.
Yeah.
After the surgery, and I didn't really where to put the light when I got.
So, you know, it does hurt. I'll give you another statistic, though. America is 5% of the world's population. 5%, 330 million. We use 80% of the world's narcotics. So there's something different about our perception, too. So, you know what? It's not your stomach, it's your knee. You know, there's no free lunch. It's going to hurt. We do the best we can. And most people, it's all patient engagement and education now. So we do pretty well with that, you know? Because when we put that crown on the bottom and we skim off the cartilage, that meniscus goes away. So there's no cartilage in the knee when we are done. You will never, ever get arthritic pain in that knee the rest of your life. It's biologically impossible. Yay! People go, great. And then they'll come in and they'll say, oh, my knee hurts. I had a knee replacement. I go, you didn't have a knee replacement, just like Mike said. You had a cartilage resurfacing. We didn't replace your soft tissue. We replaced the hot dog, not the bun. So you got the soft tissue, muscle, tendons, ligaments. You can still overdo that. You can still get achiness. And really at a year, 90% of patients will still say, I have some stiffness in there coming down the steps. I still feel not like I did. And that's what takes a year to sort of forget about it. But you get over 70% at 4 weeks, about 90% at 12 weeks. That last 10%, there's no such thing as minor surgery. I remember when I trained a hand surgeon, you know, he would do a carpal tunnel and a little Dupuytren's or a trigger finger, little procedure. And he goes, there's no such thing as minor surgery, even hand. You do that, you'll know it for 6 months. That little incision, you will know it, you know. So you will know there's no surgery that you've had that you don't know you've had for a year, you know. Yes?
I can't imagine being able to get into the car a couple of hours after knee surgery.
The trunk, we put you in the trunk. No, no trunk.
I had one 12 years ago. And,
Pickup trucks only, that's all we operate. So you could bend it afterwards. So what we do is you're allowed to bend it, and there's virtually no pain the day of surgery. It's a good trick. But so we don't put people in the back seat. That's dangerous. Most people can sit in the front seat unless you're 6'7". We put it back, and you're reclining. So you're almost sitting like this with the pillow under it, like you are in the recliner chair at home. And the only thing we tell people is, you know, we learned this over the years, but we have people keep their legs stiff when they get up or down. And it's not that they can't bend it, but, you know, if there's a problem, we've seen it. And people used to plop. So we don't want ploppers. Plop. Ah! You just bent that knee 120 degrees, and all that's holding that skin together now is some sutures and glue, because we're not using staples anymore, rarely. So we don't want people to plop. So a couple times a year, someone will fall or bend it. So we teach them the first couple days, just keep it straight, you know, when you're getting up or down. So all these, you know, things were evolution. You have 2 good arms and a leg. So even on the toilet, people want to put their leg back and lift, but we go, no, don't do that. Leave it out. You know, it's just like the chainsaw. You don't want to go bending it the next day. So just lift yourself up, and we teach them, you know, how to do that. We've been doing it 12 years or so. Outpatient, we've started in 15. We have over 3,000 like Mike. But everybody's different. I mean, I could have...
Brace didn't work for me.
Yeah.
It
So,
worked.
but
Brace hurt me.
everybody's different. Yeah.
This one back here, if she were, say you would decide she would need that resurfacing, would she be able to expect to do exactly what she's doing now? Would
So,
she be able to do that, say within a year? Or
yeah. So I'm very careful not to look in the crystal ball.
Yeah.
And you know, I tell patients that. And so when people come in and they're, you know, I have patients playing tennis and they're skiing and it hurts, and they go, you know, I ran 4 miles, but it's killing me. I want my knee replaced. And I go, you're the worst patient for me. Like, the worse they are, the easier it is to fill their expectations. So I say, really, you're skiing, you know, 4 hours a day, and it's, you know, I'm not doing this for you to ski better. We have people with both the knee replacement skiing 40 times a year doing great, but I don't do it under the auspices that I can predict that. So everybody's different, which takes a long conversation when they come in. And really, I think of myself as a life coach. I'm not a knee surgeon, I'm a life coach. So I sit there and you listen to everybody's life and figure out how can I improve their life through their knee, but you have to learn where they're going with that, you know?
Okay, I have
Yeah.
a question. What if, when you get this done, are you allowed to go up and down the steps?
Same day if you want.
I mean, because well, the bathroom's upstairs.
Yeah. I always say it's a luxury to stay on one floor for a couple days, and I go, you're going to have to go up one step at a time for the first week or so. They go, I go up one step at a time now.
Is there a weight restriction? Because I babysit my great-grandson, and he wants to be held all the time.
So do you mean
You know, up and down.
what you can lift, you mean?
Yeah.
So I always say the knee we put in isn't a motor. This is not a motor. This is a crown on a tooth. You put a crown on a tooth, you got to chew. It doesn't chew your food. So you put a knee in there, it doesn't lift you, it doesn't make you run, it doesn't go faster. All it is a crown on the end of the bone. What lifts you is your muscles. So your only limit is your strength. And so we have no weight limit after these once it heals. It's really a function of your muscles. The misinformation is these knees are designed to kneel on. You will do no harm on these knees kneeling, but it may not be comfortable. My knees aren't comfortable. People come in like Mike. I have people like Mike that are roofers, and they're back working, kneeling after knee replacements. And then you have people that say, I can't kneel on my bed because it hurts. And so there's a sensitivity around there. We try to put the incisions off to the side so they're not right in the middle. The incision will hurt you for a year, but you will do no harm. But 90% of people will have to put some pad or pillow down to do it. Yeah.
Can I say something about it?
Oh, you may.
I had this one done about a year and 3 months ago. I can kneel on this one. No problems, but like you said, you need a pad.
Once you decide, it takes about 4 to 6 weeks for us to tee it up, which is very good because once you have a date, within 30 days, you need a minimal workup, which is really an EKG, blood work, and usually a medical evaluation by your family doc. And that usually takes, so it works out perfectly. So I think most high volume, all I do are knees. I don't do hips, I don't do shoulders.
So you're saying like within 2 or 3 months?
4 to 6 weeks.
4 to 6 weeks.
And now that we have this place up here, because of Christine, it's great. So we've added 2 extra surgical days a month here. So, with our team, we bring the same team every place we go. So it's the same people. And that's a value. I mean, people don't have that luxury around the country. They'll go into a room, they just did a gallbladder. They don't know, but we have the same team. We have 3 people around the table that have done thousands of these. We don't even have to say the next step. It just comes. So it's kind of like an orchestra. You're not in the OR long. Around the country, most centers of excellence, you should, a total knee should be done in an hour or less by experts. The biggest risk is you're in the OR over an hour and 20 minutes, your complication rate goes up. Yes, sir.
Is it all done by robotics?
Sorry?
Robotics?
I've been working with robotics for 10 years. We just brought it into Lehigh Valley over a year ago because I thought it wasn't at the point where I thought it would improve outcomes. And so now we know exactly when to use it.
You don't use it in every case then?
So we don't use it in every case. After doing 20,000 knee replacements and maybe now, 500 robots, we know exactly who to use it in. There's benefits and there's cons to it, So, and again, there's misinformation out there. No matter how you look at it, the robot takes us a little longer. We have to put a couple extra things in the bone, the antennas for the robot to listen to it. And then we had to learn the robot. The robot isn't perfect. So you better know how to fly the plane when you have it on autopilot.
With the pain management, is that suitable for every patient regardless of their medical history or the medications that they currently take?
Nope. So, that's our foundation, but there's people that are allergic to them, they have sensitivities, they have kidney failure, they have high blood pressure. So we have to adapt that. But the value of what we do is nutraceuticals are a lot easier to prescribe than medications because that's natural substances. So we always have a default. So for us, if you can't take anti-inflammatories because you have kidney failure, so now we can go with Tylenol because Tylenol is metabolized in the liver. We could give you nutraceuticals. We can give you local blocks. And the best pain relief is rest, ice, and elevation. So it's not pharmaceutical. There's a lot of other issues, Yes, ma'am.
Would CBD oil be considered a nutraceutical pre?
I love it. But CBD is like nutraceuticals. They're not regulated by the FDA. They're not third-party tested. So every vitamin that you buy, you don't know if it's junk or if it's good. So I give a little handout to people to know how to do that. Because the quality nutraceuticals will send it off to an independent third-party lab. They will give you a value analysis and they will tell you what's in that. CBD, I have a whole hour talk on CBDs. I can't even tell you today. But that too, Rockefeller stopped that in the 30s. The reason we don't know much about marijuana and CBDs is because it interfered with the industrial magnets in the 30s. So it interfered with industry, hemp, paper production, pharmaceuticals. So it became a Schedule I drug for 100 years. All research was stopped on that. So that's why we're sitting here like a bunch of idiots without much research on it, because the government still has it as a Schedule I drug. But the hemp-based CBD with no THC or less than 0.3% really is part of every physiologic reaction in our body. So long story, if it's third-party tested and it's you could document that it like a vitamin, that it's clean and then it's safe, THC is under 3%, then by the Farm Act it has been legal for people to use. There's a lot more research to be done, but it's probably one of the safest molecules on earth. I was out of medical school before they even discovered the endocannabinoid system, perhaps the most important system in our body that modulates every physiologic function that we have, and we didn't even hear about it in medical school. So there's a whole bunch of research to be had, which is exciting. So it got hot in here. You were a great audience. We could probably go on for hours. Maybe we'll just have another one someday. But thank you for coming. I really appreciate it. Mike, thanks. Christine for putting it on. Mike for everything. Thank you very much.